So without further delay, I would like to invite Professor Tom to give his presentation. Tom is a research education academic director in the Faculty of Medicine and Health at the University of Sydney, and also research fellow in the Department of Cardiology at Royal North Shore Hospital, Sydney. He has over 30 years of experience in intensive and coronary care and established international research profile investigating the relationship between emotions, physical stress with the onset of cardiovascular disease. In his doctoral studies, he had investigated the psychological, physiological, and behavioral changes associated with spouse and parental bereavement. His work has been incorporated into Heart Foundation's positional statement on psychological risk factors for cardiovascular risk. His latest work has confirmed that hospitalization is a potential trigger for cardiovascular events due to psychological and physiological disruptions. Let us invite Tom.
Thank you, Dr. Lee, and an absolute pleasure to be here. Thank you so much for inviting me. I will now try to share my screen, and this is where we all hope that the technology works beautifully. Hopefully you're now seeing my home page. Is that correct, Dr. Lee? Can you see the right page?
Yes, it looks perfect.
Thank you. Great. Always good to make sure the technology works before we start. Greetings, and such a pleasure to be here. I know we're going to talk about a topic that's very personal, and I guess one of the best places to start is to introduce the research team. So to do this type of research, of course, we require a very a team of experts, interdisciplinary or multidisciplinary experts. And here we have some people that may be known to some of you. Dr. Mihailidou here at the back, who will speak after me. Professor Toffler, Professor of Cardiology, Professor Bartrup, who was a psychologist and a physician, who was the very first person to explore the physiological consequences of bereavement in 1977. It was originally published in the Lancet. And in some ways, I was very fortunate for my doctoral studies to be supervised by Professor Bartrup and Professor Toffler and Professor McKinley here in intensive care, Professor of Nursing, because Professor Bartrup, it was a lifelong quest of him to truly unravel this link between psychological stress and this phenomena of prevalence of cardiovascular disease that people have reported anecdotally in their practice, and as I'll show you in some of the research, has been borne out in the research. Some of the other team members here, Professor Ward, a hematologist, Monica Spinazzi, registered nurse, and Dr. Morel Kopp, a hematology scientist, as well as two social workers here, Margaret and Jenny, and Di, who's a chaplain in the intensive care unit, and Michelle, who's an ECG technician. So as you can see, it was a very large team that undertook this research. Now, before I start, just because I will talk about bereavement and I'll talk about grief, and I may talk about predictors of complicated grief, I think it's always worth stopping and saying, you know, when we talk about grief, we really are talking about this complex set of cognitive, emotional, social difficulties that follow the death of a loved one. When we say somebody's in bereavement, what we're really referring to is the context of what's going on, but the individual is most likely suffering a grief reaction. And what we do know about grief and people's bereavement experience is that it varies enormously from the type of grief, the relationship with the lost person or the person who just died. It's the experience around the death, the intensity and the duration, and often how people express their grief can vary from individual to individual. Now, when you look at the literature, we often refer to complicated grief reactions, and some people, there's a lot of different terminology here, and some will refer to as atypical or prolonged grief or morbid grief. Pathological grief is a terminology that's often referred to, and not everybody associates with the concept of pathological when it comes to grief. Abnormal, and it's very difficult to differentiate what's normal, neurotic. So older literature will talk about depression of widowhood. And I think I personally, usually when I talk about complicated grief, I'm really talking about unresolved grief, knowing that we really can't diagnose a complicated grief reaction until about 6 months after the death of their loved one. And when we actually look at how we diagnose that, unresolved feels like the more appropriate term to me. But as I say, people will use different terminologies. That we would probably all, either in our personal lives or on social media or in the press, or in our professional lives, be aware of couples who spend a long period of their lives together, and one dies and their partner passes away very soon after. And I certainly witnessed that myself many times working in acute coronary care units and intensive care units. So most of us probably have a story around having witnessed this phenomena. And I guess when I started this journey on my doctoral studies in 2009, many people said to me, many friends said to me, or colleagues said to me, oh, but that's not really true. You know, that's a bit of folklore or an Irish saying for, you know, when people think it happens, but it doesn't. But when I actually reviewed the literature over about 40 years of literature, there is a significant body of literature identifying this increased cardiovascular mortality. The highest risk seems to be in the first 2 weeks, which on average is about sixfold, although the risk is much, much higher in the immediate days, up to about 18-fold in the first couple of days. But averaged over the 2 weeks is about sixfold and remains elevated to 6 months, starts to drop off at 6 months. And if you interrogate the literature, again, the risk increases back up at about the 12 to 13 month period. And what's very interesting about that literature is that when you look longer term, and particularly in widows, what you find actually is that the risk falls off after about 4 years. And actually at 4 years, spouses who survived their other partner are about only at 50% of the mortality risk of married counterparts. So it's almost like having experienced and survived the trauma of losing your loved one, particularly a spouse, actually in the longer term decreases your cardiovascular risk. And we don't fully understand that. What we do know is that men and women are both at risk, and the risk is increased across all ages. When you look at the causes of death, what you find is that up to about 50% of the XX deaths are related to cardiovascular events, and that was the subject of our investigation in this study. There's been some suggested hypotheses for this phenomena. It's been proposed that people share the same pathogenic environment and therefore may carry some of the same environmental or behavioral risk factors as their spouse. There is a known tendency of unfit to marry unfit. There is a proposal that lifestyle or health behavior changes that occur during the grief process, disturbance to sleep, mobility, eating, alcohol, smoking, use of drugs, or even perhaps not taking prescribed medications could be a contributor. And there is the proposal that is the impact of the grief reaction, the impact of the physiological response to depression, anxiety, and anger. We reviewed that literature, and what was very clear from the literature was that when you controlled for the pathogenic environment, or you controlled for people's cardiorespiratory fitness, or you controlled for the altered lifestyle behaviors, you found that there was still an increased cardiovascular risk. And that led us on a journey to try and determine what are those risk factors. So in 2007, in a textbook, we proposed this model where we identified psychological responses, looked at some of the modifiers such as social support. We were aware of some of the literature on dietary and sleeping behaviors, but we did an in-depth investigation as it hadn't been done, looking at hemodynamic changes, prothrombotic changes, endocrine, inflammatory immune changes. There had been some prior work on immunology, as I say, from Professor Bartrop's work in the 70s right through to the 90s. We investigated, looked at lipid profiles, and we looked at platelet activation. So we looked at what some of the common physiological disruptions, stroke risk factors that we would expect to see that are associated with a transient risk of coronary occlusion. And coronary occlusion is or plaque disruption is the phenomena that we were investigating, as opposed to looking at Takotsubo, which also has an association with grief reactions. So the purpose of this study was to, as I say, was to look at these physiological responses that are potential acute risk factors for AMI and sudden cardiac death. We did a cross-sectional longitudinal evaluation, recruited patients from a hospital setting here in Sydney, recruited 2 groups of relatives related to spouses, partners, or parents of patients who had unfortunately deceased in the hospital, or of patients who had been successfully discharged, predominantly from orthopedic areas where we recruited our control sample. I went and saw the individuals in their home within the first 2 weeks of their partner dying, and did the initial assessment, which included the physical assessment, hemodynamic with 24-hour heart rate, 24-hour blood pressure, took bloods, which I'll present some of the results later, and did a psychosocial assessment. Followed up at 3 months with a psychosocial assessment. And again, at 6 months, I saw both the bereaved participants and the controlled participants in their home, and repeated the same follow-up 24-hour assessments that we did in the first 2 weeks following the death of their loved one. So we assessed 80 individuals in each group. All were spouses or parents. The majority were spouses with a small number of parents. We approached all participants within 72 hours of the death. Majority were approached in the hospital. Some were approached the day after the death. And all the assessments were controlled and standardized, done in the morning. And the mean day from bereavement was day 11, although we did see people within the range of 4 to 16 days. The 2 samples were very, very similar. The only statistical difference was that, and you probably would be unexpected, that more of the bereaved sample were living alone at the time of the assessment. Completely expected, considering their spouse, for most of them, had just passed away. Other than that, socio-demographic and social support, they were very, very similar samples. And likewise, in their medical history, no significant differences between the 2 groups. So some of the results from that study then, expectedly, I guess we weren't surprised to find that symptoms of depression here at the acute assessment in the first 2 weeks were significantly higher than the controls, did reduce at 3 months. The biggest change was seen between 2 weeks and 3 months, and then a small but non-significant change from 3 months to 6 months. And the control sample relatively slightly higher here in the control. Remember that these controls were relatives of hospitalized patients, so they would have had some degree of hospitalization stress, but nowhere near compared to the bereaved sample. And a similar trend with anxiety, significantly higher in the early period, reduced at 3 months, reduced again at 6 months. These lines here are the recognized clinical cutoffs for these instruments. And as you can see, the bereaved sample never came down below the sort of recognized cutoff of 30 of clinically significant anxiety symptoms, but they did with depression symptoms at 6 months. Anger was not very prevalent in the group. Although one of the things I would say, having worked with these individuals and assessed them, is that when anger was evident, usually there was significant events either in their life or during the hospital stay that had triggered that anger. And some of those events often related to the clinical decision-making that needed to occur in the hospital around the care of their loved one. And sometimes it was towards the loved one as well, for perhaps not acting on their health ailments, or in some scenarios, discovering things about their partner or their husband after they had passed away that perhaps they didn't know. One example, such as illegitimate children, other things related to wills and sort of financial arrangements that they weren't aware of until their partner had died. So anger wasn't very prevalent, but when it was a significant event in these bereaved individuals. Look just briefly at the predictors of depression scores. Age was a factor, and it's known that younger individuals tend to have a more intense grief reaction, whereas but then recover quicker, whereas older individuals tend to have a less intense grief reaction, and but it's much more prolonged. How prepared for the death was a predictor. and sleep, and that bidirectional relationship between sleep and depression is fairly well known and something we saw in this study too. And when we looked at their health behaviors, about 60% of the sample reported that their alcohol intake had increased, but the majority of the sample had much significantly reduced food intake, significantly reduced appetite. So that was mainly no changes in smoking, very, very few smoked in the study anyway. From a biological or physiological perspective, that was mirrored with lower cholesterol in the early 2-week periods that at 6 months had increased, and in the bereaved sample, and likewise LDL levels, which I guess you would associate with lower cardiovascular risk, were lower in the early phase, that increased again at 6 months. So that's more likely reflective of their reported lack of appetite and lack of eating in the first 2 weeks of their grief reaction. Cortisol levels were higher in the bereaved sample compared to the control sample, and they didn't decrease. And that was one of the phenomena that we've noticed with cortisol, was that it continued to stay up despite some of the psychological measures coming down. But remember that, as I said earlier, the anxiety levels had not returned anywhere near normal levels, which may account for that. Sleep had improved significantly over the 6 months to control levels. And what we saw with cortisol was that it was associated with those who had increased their alcohol consumption, and also higher in men compared to women, whereas lower sleep times associated with lower satisfaction with social support, increased associated with depression, reflective of some of the early results, and also in those who had anger symptoms, higher anger symptoms, then lower sleep time was associated with that anger. From a thrombotic perspective, the main changes we saw were in von Willebrand factor and factor 8, with both of them elevated in the 2 weeks post-bereavement and reducing to control levels at 6 months, and a similar pattern here in factor 8. And we also saw increased neutrophils and monocytes in the early bereavement periods that decreased at 6 months, mirroring what we see here in the prothrombotic factors. I won't dwell too long on blood pressure because Dr. Mihailidou will speak about that, but just to mention that blood pressure was increased, but we'll come back to that. And it was associated with anxiety and anger symptoms, perhaps not unexpectedly. 24-hour average heart rate was increased in the bereaved in the acute phase, that reduced to control levels at 6 months. And it's interesting that we separated those that were on heart-lowering medication, which is just a small group, that the changes, decrease was seen in those non-medicated. But of course, those medicated had a lower heart rate, which you would expect. And we thought that was quite important to look at that more carefully, which I'll talk about towards the end of my presentation. Higher heart rates associated with lower satisfaction with social support, higher depression and anger symptoms. So we can start to see this trend of higher physiological disruption associated with higher psychological stress symptoms. When we looked at the 24-hour heart rate variability, 24-hour heart rate and heart rate variability monitoring, what we saw was a trend towards higher atrial ectopics, non-sustained short bursts of supraventricular ectopics in the early acute period in the bereaved, that we didn't see so much in the non-bereaved. And likewise, we see reduced heart rate variability across multiple measures, standard deviation of normal to normal intervals, PNN50, and in a high frequency and low frequency bands, sort of reflective of reduced vagal activity or reduced parasympathetic activity during the grieving period that improved over the 6 months. When we looked at the relationships, and it's a busy slide, and my apologies for that, but we did see that these changes in heart rate in short either ectopics or arrhythmias, and the high frequency, low frequency, or the parasympathetic high frequency band, that they were associated with either depression in some instances, anxiety in many incidences, and cortisol, and sort of pointing to that more intense grief reaction associated with more disruption to withdrawal of parasympathetic activity and more proneness to ectopics or short runs of VT on the 24-hour heart rate monitoring. So in summary, what we did see, if we go back to the model that we had proposed areas, we did see increased depression, anxiety, and anger, probably unexpectedly. We saw that social support was a potential modifier, and those that felt they had more social support felt had tended to have lower depression, anxiety, and a quicker resolution of symptoms. We saw decreased sleep, increased heart rate and blood pressure, increased prothrombotic factors, von Willebrand factor 8, increased cortisol, increased mobilization of white cells, neutrophils and monocytes, decreased lipids that increased over the 6 months. We saw some increase in platelet leukocyte aggregates, once again pointing to the increased platelet activation, and we saw decreased heart rate variability measures. Now, some of the interesting things before I hand over to Dr. Mihailidou to explore the hemodynamics a little bit more. People are always interested in coping and how people cope. And what we noticed was that coping was fairly stable across the 6 months. Not unexpectedly, acceptance increased slightly over the 6 months, and likewise planning. But the other aspects of coping, emotional support, religion, positive reframing, self-blame, they remain fairly stable over the 6 months. And this is just a hierarchy of what people reported that their coping strategy they use most. So acceptance, active coping, self-distraction, planning, emotional support, and religion, positive reframing, and social, they tended to be the higher coping strategies adopted by participants. I was very interested in what were predictors of unresolved or prolonged grief, and how prepared people were for the death was a significant multivariate predictor of grief reaction at 3 months and also at 6 months. And I think that's important because as clinicians, we have the ability to help people prepare in some environments for the death of their loved one. And that was the independent predictor of prolonged grief. When we looked at their coping strategies, we looked at what their coping strategies associated with the higher intensity of grief at 3 months. Denial was the independent predictor, those in denial. And I found that one interesting because other studies have shown that if you can help people to prepare in that anticipatory grief period, then you do have some impact on reducing the intensity of grief reaction. Those that needed more emotional support at 6 months tended to have higher prolonged grief reactions. And importantly, those who self-blame and denial again at 6 months. But self-blame is very interesting because there is one small pilot study that's shown that if you can help people to resolve that self-blame, and in that study, they got relatives to apologize to their partner for whatever it was they were self-blaming. That when they did do that, they had a less chance of having complicated grief reaction. Once again, providing a window of opportunity for clinicians to ask people, is there anything you would like to say to your partner before they, even if they've passed away and they're still in the hospital setting, there's still an opportunity there to for relatives to express some of the things that they might be blaming themselves for. And that seems to help people to resolve their grief reaction a lot quicker. We did look in the literature, published a paper in Dialogues in Clinical Neurosciences, looking at what interventions are there to reduce cardiovascular risk and bereavement, and there were none. They were interventions to reduce psychological symptoms, to try and reduce cortisol, to increase sleep and immune function with varied success, and often in some cases with some psychological interventions, actually patients tended to have a more intense or a more prolonged grief reaction. So once again, probably related to the individual nature of people's grief reaction. So we performed a study where we tested low-dose metoprolol and aspirin in a sample of 73 spouses and parents in a similar setting to where we did the first study, and then measured the same physiological factors in these psychological, behavior, and physiological factors in these participants over a 6-week period. And what we found was that low dose, just one low dose of 25 milligrams metoprolol and 100 milligrams of aspirin in the morning for 6 weeks reduced heart rate and blood pressure throughout the study period, improved measures of heart rate variability, reduced thrombotic measures, reduced anxiety, depressive symptoms, and we saw no significant effect of bereavement intensity. And we monitored that carefully because that people will often speak to beta blockers increasing depression symptoms, but actually we saw the opposite in this bereavement study. And after 6 weeks off therapy, what we saw was the psychological measures continued to downward trend, but blood pressure that had lowered in the acute phase remained lower off therapy. So 6 weeks off therapy, the blood pressure remained lower. And we thought that was quite important because other studies have shown that blood pressure tends to remain elevated. And in some studies, blood pressure can remain elevated 4 years after bereavement. And here we show that by treating blood pressure early in the grief response, it remained lower after 6 weeks. Heart rate returned to placebo levels, and we saw a negative trend for autonomic function, and thrombotic measures were similar between groups after 6 weeks of therapy. So I'd now like to hand over to Dr. Mihailidou, and I'd be very pleased to take questions after Dr. Mihailidou's presentation.
Thank you, Tom, for the very interesting lecture. I think we are all quite enlightened about grief and also its effects and its possible treatment. For the audience, you can actually, if you have any question, you can type into the Q&A box. You do not need to wait till the end, but we will answer the question by the two speakers at the end of the presentations. So you can type into Q&A now if you have any questions. So without further delay, let us welcome Dr. Anastasia. Anastasia runs the diagnostic service for 24 hours ambulatory blood pressure monitoring at the Royal North Shore Hospital in Sydney. She also engages in both biomedical and clinical research as the head of the cardiovascular and hormone research laboratory at Rolling Institute and also honorary senior lecturer at Macquarie University. Her research focus is mineralocorticoid receptor regulation in the heart, sex differences in heart diseases, and blood pressure regulation. She was part of the executive committee for initiating a national multi-center study for deriving reference BP level for ABPM threshold for the diagnosis and management of hypertension. Her recent appointment is at the Lancet as one of the commissioners for the Commission on Cardiovascular Disease in Women. And Anastasia is also currently on the HBPLCA executive member responsible for education and also the vice chair of the International Society of Hypertension Communications Committee. Let us welcome Anastasia.
Thank you, Eric, for having me and for the invitation, and also to Nellie. I'm honoured. It's big shoes to fill coming after Professor Buckley because he's the leader in this field. But I'd like to focus on our exciting findings and important findings in terms of the blood pressure response. So I'll share my screen. Hopefully, are you able to see that? Wait a sec.
Yes, but it's not a full screen. Yeah, it's full screen now. Thank you.
Full screen now? Thank you.
Yes, thank you.
So I'd like to focus on specifically, rather than Professor Buckley covered very extensively the overall findings of the project, but I would like to highlight something that we observed. And the importance of this is that I'm sure Professor Buckley mentioned it, but to highlight that prior to our study, there hadn't been any other studies that looked at this early within the 2-week period for obvious reasons. This is a very difficult study to perform, and I commend Professor Buckley and our nurses who went in there and social workers to encourage and collect this data. Interestingly, it's given us important insight, and it's important to highlight to all of you that it's important that it's not only the emotional and the psychological, but as you saw from the data, the physiological changes that are happening. So I wanted to highlight firstly, because we're looking at ambulatory blood pressure monitoring, and Professor Lee has mentioned that not everybody uses ambulatory blood pressure monitoring. So I thought I'd just give a brief, if you allow me, just a brief overview of why we would like to have ambulatory blood pressure monitoring. It's important to highlight that in the clinic, as you all are aware, many people have what's called a white coat effect. In Australia, it's about 15% of the population, but I'm sure you see it all in your clinics or as health professionals. It's via most of the guidelines, international guidelines, out-of-office blood pressure measurement is is essential in confirming diagnosis of hypertension and management. And while with the pandemic, home BP was the preferred option with telehealth, we find that ambulatory blood pressure monitoring over the 24-hour period will, in the person's typical day, will show you the fluctuations and the variability during those activities, but especially during sleep and awakening, which are independent, particularly nighttime blood pressure is an independent predictor of cardiovascular risk. There are home blood pressure monitors, but up until recently, they weren't able to detect blood pressure at night. There are new ones, but they're still in testing stage. And certainly the importance of ambulatory blood pressure monitoring is it detects isolated ambulatory masked or reverse white coat hypertension. And rather than going into details, because this webinar is on bereavement, I just want to highlight that the rise in nighttime blood pressure or the lack of dipping, even when the person has slept, is a very powerful, easy and early warning sign that there's some abnormalities. And this can happen even when people have normal office blood pressure values. And if you're not sure of what an ambulatory monitor looks like, it's very portable. It sits on the waist. It's an arm cuff similar to what we measure in the clinic, and the person can go about their normal activity. But of course, they have to remain still for during the measurement. And you can see here, I don't know if you can see my pointer, but you can see in the top trace, if they move during the monitoring, then that can cause interference. So it's important to highlight to the person that they need to remain still just when the measurement is taken. The beauty about it is that, as you can see, you can pre-program it to take measurements anywhere between 5 minutes, which we don't do, but typically it's between 15 to 20 minutes during the day and half an hour to an hour during night. And as you can see here, there are several fluctuations. In this particular instance here, you'll see that the thresholds are exceeded during nighttime sleep. And without going into too much details, I just wanted to highlight with this particular table, this is from the Australian blood pressure guidelines, but they're universally the same cutoff or thresholds, that ambulatory blood pressure cutoffs are low, or the thresholds are lower than clinic blood pressure measurement, and are very similar to the home blood pressure. So the cutoffs are 135 on 85 and 120 on 70 for nighttime. It's important to highlight that one thing that is overlooked is the patient compliance. And while most find it uncomfortable, and certainly our bereaved, quite a few of our bereaved patients didn't like wearing it at night, and understandably, on the whole, most people tolerate it because it actually engages them in their personal health management. By seeing this trace after when they revisit their referring physician, it really is quite empowering, because as a patient said to me today in clinic, I don't feel these high blood pressures, and it's concerning to me that I can have blood pressures, at 160 on 110, but I'm not feeling anything. And so this is the importance, that we really need to engage people in their health. So on that note, I'll move to our data. And as Professor Buckley highlighted, I'm just recapping, it's one of the most stressful of human experiences that we're all going to experience at some stage. And he elegantly showed the increased risk to cardiovascular disease by the extensive metrics that we took for this study, and commending him and the rest of the team, particularly in the first 2 weeks after the loss of the loved one. And we followed them for 6 months, and Professor Buckley and some of the team have extended that monitoring further. And importantly, we measured these physiological measures, because hopefully, if we can understand the mechanisms, we can tailor the preventative strategies. So it's not just in terms of counselling, but it's maybe also, as he showed from our CARBA-2 study, involved treatment. And so I'm focusing on ambulatory monitoring because, importantly, it hasn't been measured in bereavement prior to our CARBA study. And ours is a prospective, as you would have heard from Professor Buckley, ours is a prospective controlled cohort study. If you want to read the studies, we can post with the webinars the articles or the links to the articles so that you can download and read them at your leisure. But I would recommend that you do read them, because they highlight important measures that we need to all be aware, not just for our patients, but for ourselves as well. So I know Professor Buckley went through it, but it's important I'm highlighting that while we had 80 subjects in each arm, with the ambulatory monitoring, we only had 62 bereaved spouses and 50 non-bereaved. As I said, not everybody tolerated it. And also, if there were missed readings, you couldn't really use the 24-hour monitoring. We used a validated machine. So it's not only the clinic measurements that have to be validated, but the device has to be validated so that they're reliable measures. And we looked at the analysis, and I won't go into the statistics of it, but to highlight that those who were on antihypertensive medications it was noted but by self-report rather than any records. And so, just summarising, because Professor Buckley has done it very elegantly, I just want to highlight that a large portion of our cohort was female, both in the bereaved and non-bereaved, and that's in fitting with. We know women live longer than men, but also in terms of bereavement, we see that quite often. And there's a broad range, but they were matched in terms of most variables and in terms of antihypertensive treatment. I just highlight down here that they also matched in terms of potential sleep disturbances or problems, of course, self-reported again. So the important thing is that these were well-matched groups, and highlighting that this is the message I want to highlight, particularly for the female part of it. While we're not powered to make a statement about that this is particularly for females, because we didn't have the numbers. We selected based on bereavement and matching the two groups. It's important to highlight that women tend to get, as you're probably all aware, under-recognized in terms of cardiovascular risk. And we need to be aware that they probably need to engage with their health a lot earlier. Many know about it, but many don't recognize it, and the symptoms may be different, and particularly with hypertension, because hypertension is the #1 risk factor for women. It's #4 for males, but it's #1 for females. So this is starting earlier, and we really need to be aware of that. I've just put up the overall summary, and here you can see this is the open circles represent the non-bereaved group, and the filled circles relieve the bereaved group. And you'll see this is a 24-hour analyzed data for each hourly means over the 24-hour period, and you'll see the diurnal variation. And while there was no difference in diastolic blood pressure between the two groups, there was a significantly higher systolic blood pressure over the 24-hour profile, particularly for day rather than night. And part of that reason is because our nighttime measurements, as we said, we may have been underpowered to detect that difference. Having said that, the fact that so you have to remember, differences in ambulatory blood pressure are not as marked as they are for clinic. So a 2 millimeter difference in mercury on ambulatory is significant in terms of overall effect. But importantly, between the groups, that physical activity didn't vary. We did it by self-report, so there may be limitations, but we did ask them and it didn't vary. So this difference in blood pressure was, as Professor Buckley highlighted, related to other mechanisms, some of which we can't really tease out based on these studies, but certainly it's important to be aware that the systolic blood pressure was elevated over that 24-hour period. Having said that, I've just highlighted here the table and also just summary data so that it highlights that while clinic blood pressure was higher for the bereaved group compared to the non-bereaved, by 6 months, importantly in the bereaved group, it hadn't resolved. And that's really important to highlight, because while the other hemodynamic parameters did resolve and diastolic blood pressure resolved, systolic blood pressure didn't, and it persisted to 6 months. And as Professor Buckley highlighted, so did cortisol, which I find really interesting and may be an indicator of potential mechanism apart from the stress contribution. What is interesting, as I've just summarized here, is that heart rate resolved from the acute to the 6 month interval. So we have this persisting systolic blood pressure in the bereaved group. Certainly in the non-bereaved, we didn't see those changes. And we also measured blood pressure load. Blood pressure load is defined as the systolic blood pressures above 140 millimeters of mercury and a diastolic blood pressure above 90 millimeters of mercury for daytime. For nighttime, it's above 120 millimeters of mercury, and for diastolic blood pressure, it's above 70 millimeters of mercury. And you'll see here so the first two panels, apologies for the colors here, are the daytime systolic blood pressure for bereaved and non-bereaved. So you'll see there's a markedly larger load. So the majority of the daytime were above 140, which fits in with our other findings. So there's confirmation that we're looking at it in different ways, but it's confirming the data is that these pressures, without people feeling anything, are elevated, and they really need to be addressed, because these people are not aware of these increased pressures, but if they're already at elevated, they may be higher. So, and similarly with diastolic blood pressure, the daytime were elevated, but we didn't see that by 6 months. It was only the systolic blood pressure, daytime systolic blood pressure was elevated. I've just repeated what Professor Buckley highlighted, just to remind you that these increased systolic blood pressure was associated with increased anxiety symptoms, as well as anger symptoms, but also increased cortisol. And while that's an association, my own data and others from the literature do show that cortisol in high redox state can have detrimental effects in the cardiovascular system. So at this time, when we did the study, I saw it as an association, but I'm very intrigued to see that these results match with my biomedical research and also with clinical research in heart failure. I'm not going to present for the interests of time because I really want to spend more time with the panel discussion and taking your questions, but we also saw increased blood pressure variability. So increased blood pressure variability, as you're all aware, is associated with high cardiovascular risk. And so we measured metrics of those, which is standard deviation and coefficient of variation. And we saw increased blood pressure variability in the acute, but not the chronic or the 6-month phase. I have to highlight that while these were part of the research program, many years after our study, Professor Buckley, well, actually, I should say it was circumspect. I want to highlight an observation, which is we presented to the Medical Journal of Australia as a case report. And what happened was, here in Australia, we had some events which were, we had a massacre, and we also had a young cricketer who accidentally died by being hit by the ball. And they publicised his funeral. And at the time, I didn't realize it, but I had 5 people wearing ambulatory blood pressure monitors for assessment of their blood pressure, quite independently of any bereavement study. But importantly, I interpreted those reports based on the findings of the activities. And I'll just show you here the traces. These are 2 of the people who watched the funeral. So what happened was, I didn't make anything of it, but I highlighted that they were on the traces, as you can see from, I don't know if you can see my arrow, but this period here where they're sitting watching the televised funeral, and you can see it's almost equivalent to their activity when they're washing. It was almost a 20mm increase in blood pressure. And here it's a small blip, but it's real because we know that it can trigger an alerting response. But I didn't make too much about it until I was sitting in the hairdressers and we were discussing amongst women. And one of the women said, that's it, I'm not listening to any media reports. I'm tired of hearing about all of these, bad situations and events. And it made me think about these 2 studies and how the fact that I had observed it. And I went back and with Professor Buckley and our collaborators, we put together this report. And to our satisfaction and gratitude, the Medical Journal of Australia highlighted what I aimed to do was to highlight the importance of media has, and particularly, this is before pandemic, but we know now, we have to be aware, the reason I highlighted this, we have to be aware that the events that are being televised through the media are impacting all of us. And this is a unique situation, and I highlight it here because these are recordings which were real life and independently of any research, showing fluctuations. Yes, these people reacted, but they weren't related to the cricketer. They were complete strangers. They didn't know the cricketer. They just saw the televised event. So we need to be aware that these hemodynamic changes, the MJA, highlighted that it was, or Medical Journal highlighted that it was the impact of grief, but it's the impact of adverse events. And Professor Buckley is best positioned to continue. He's continuing that research, and we can discuss it in the panel discussion. But it's the impact of this news that is impacting us and releasing these factors, but also regulating our blood pressure. So on that note, I'll wrap up and take questions. Thank you very much.
Yes, thank you, Anastasia. It has been a very exciting, fascinating studies. Yeah, so it's time to go to the Q&A, and I can see there's one in the chat room. So from Hong Kong, how can we incorporate findings of bereavement studies in clinical settings, especially when prolonged effects of bereavement may not be easily associated with bereavement after 6 months? Yeah, so I would like invite the 2 speakers to.
I'll let
answer.
Tom start.
I was just turning a little bit of a technical issue. Could I just get you to repeat the question? Would that be okay, Dr. Lee?
Yeah, so he asked, how can we incorporate findings of these studies into clinical settings, especially after 6 months, the doctor may not, get that piece of information and may as well easily miss it. Yeah, so
yeah.
yeah.
Fantastic question, Dr. Lee. And I think that for me, the first thing is to recognize that this is a risk period. So we know from other research we're doing that people are more prone to cardiovascular events at different times in their lives. We've shown in studies that even an episode of high intense anger can increase the cardiovascular risk of a myocardial infarction by 8-fold. We've shown other periods in our life, work stress, particularly deadline stress. So I think the first thing is to recognize that when people are going through acute stress periods, there is an increased cardiovascular risk. This study gives us insights into the mechanisms of that, and it seems to be a combination of prothrombotic and hemodynamic turbulence is the word I use. I think in the first 6 months of bereavement, there's a tendency for people to say, but it's just the grief response. It's just a normal response. And one thing we don't want to do is to medicalize that response, but we also don't want people to be at excess risk and to have cardiovascular events themselves. So I think that recognition that there are people who are prone to cardiovascular events, that they would benefit from additional preventative strategies at that time. Now, we don't suggest that everybody needs to take a beta blocker or aspirin in that time, but people with cardiovascular risk already, our study would show that they would benefit from that. And it seems to be that that first 6 weeks is the highest risk period. At 6 months, it's a very difficult time because some people will have resolved their grief symptoms. We saw in our study for the majority, their physiological disruption was normalized except for blood pressure. So I think that vigilance around blood pressure, that perhaps intervening on blood pressure earlier is what we would recommend. Dr. Mihailidou may want to comment on the blood pressure, because that was the one variable, that and cortisol were the two variables that did not result at 6 months. And we didn't study beyond that to know at what point does it decrease. But I do know from other studies that blood pressure often has a legacy effect and can stay up and may never come back down. So I think intervening either before the 6 month or at the 6 months. But Dr. Mihailidou, you're an expert on this.
No, we are in agreement. Specific to the question, I think home blood pressure monitoring. We don't recommend people come back for ambulatory, but I think we want to encourage everybody to be aware. So as Professor Buckley said, those at increased risk, we don't want to medicalize it, so put everybody at risk. But it's ideal for as health professionals that we do have those people monitoring initially. It doesn't have to be ambulatory. It can be a clinic measurement and home monitoring. But what we want is for them to continue monitoring. And as Professor Buckley said, if they're at increased rates, then they're going to have to do that long term. As you're aware, Professor Lee, we want them to continue so that it's been shown from many studies that the people who manage their blood pressure or measurement do better in terms of overall control than people who rely on ad hoc measurements. So I agree, it's long-term management of blood pressure.
Thank you. There's another question. So when we know that the media actually affects the CVS risk or blood pressure, so what kind of exposure would generate more physical effects? And could you elaborate more on the mechanisms behind this?
Honestly, it's all of the above, as Professor Buckley would say. You know, it causes an alerting response, it causes release of cortisol, causes sympathetic drive. We can't control the media, but we can be aware that there will be alerting responses. Having said that, I think most people, the message that I would like is that most people need to know their numbers. And everybody knows me when I say that. It's not just their blood pressure, their overall cardiovascular health. We tend to assume because we don't have symptoms that everything is fine. And while we will all have acute changes, it's as Professor Buckley said, it's when there is underlying cardiovascular risk that those changes may reset the system. And it's a long-term phenomenon that we're aware of. I'd take it over to you, Professor Buckley. I'm not aware of how we control that mechanism, to be honest, but I'm here to learn.
Yeah, no, I agree with you. I think there's two things come to mind in relation to both questions. One is to really get that message out to don't ignore symptoms, particularly during any stress state. I mean, we're talking about bereavement and grief response, but during any stress time, whether it be divorce or whether it be following arguments, etc., with individuals, is that people don't ignore the symptoms, because I think people intuitively know that's what stress, psychological stress, isn't good for the heart. But yes, I've got a study where I have 1,100 people who have had confirmed myocardial infarction, coronary occlusion on angiogram, and I've been looking at the relationship of the events preceding their myocardial infarction. What astounds me is that people's lack of recognition of taking action when they do have symptoms. And yet they know that these events in their life are not coincidental, but when they have symptoms that occur during these events, they tend to go, oh, it's just the stress, so it's just that. And I think that's a really important message here. Recognize the symptoms in others, act on the symptoms. As Dr. Mihailidou said, get to know your numbers, be aware if your numbers are increasing, and act early. The social media one's very interesting, because I think one of our biggest problems with social media is that facts and stories get mixed up, and people have a real problem differentiating, is that somebody's opinion or is that actually a fact? And I think that's a bigger problem in society, but certainly in other work I do in a clinic I run, we see that we do a lot of what we call digital detox. And one part of that is getting our patients and clients to come off social media. And when I measure their 24-hour heart rate, when we do that, we see a similar effect to putting them on a low-dose beta blocker. And I can almost predict the clients or patients who will get that effect. So I think that hypervigilance, some of that may be the blue screen effect on their sleep metrics and decreasing. I must have monitored at least 2,000 people in that clinic, 24-hour heart rate variability, and I can predict immediately what happens when they're on screen late at night. Same with alcohol, same with emotional stress. And so I think that the digitalization is a big problem, and some of it is to do with the digital devices. A lot of it, as the person who put that question up, thank you, is indicating a lot of it is actually some of the emotions you're getting to the content from those digital devices. So it's a loaded question, and there probably isn't a single answer.
Yeah, thank you so much, both speakers. I think for the time being, because time is running short, so maybe just one last questions. So I'm thinking, so we have now known that it's actually inspiring for me as a clinician, so that I reflect on, I see these patients, I should be more vigilant about the cardiovascular events that happen soon after the bereavement process. And I also, learn about the physiological changes. It makes me reflect, should I actually take this blood, like lipid profile, right after this process, because it tends to change, it may not be stable. When should I screen for them? How do I treat them? So there's a lot of reflection actually. But as an academic as well, I think some of our colleagues will be quite interested. So what is the next planned step? Obviously the story has been beautiful, it's wonderful, but it hasn't been finished, right? So what is the next step in research, and any chance of collaboration between the universities? We'll be interested to know.
From my perspective, the latter part is always welcome. I mean, I think we only do these type of studies when we collaborate. We even did our mechanism study, if we want to call that, in one setting, in one city, in one country, and you know, that may not be reflective of your setting and your culture and people, how people responding in their grief response. So I think you know, my desire would be to see this study replicated and bigger samples, and perhaps now we have more knowledge to be more targeted in where we're looking. The next step, personally, I've been looking at other life events. We did do our intervention trial with the low-dose metoprolol and aspirin. But without doubt, you know, if I think for clinicians and if I think about you know, patients in front of medical practitioners, I think a lot about just having a visualization that their hemodynamic turbulence, prothrombotic factors, would they benefit from that therapy? And you know, we've been working with a few groups and translating that into practice. I think what our intervention study showed is that that is safe. It doesn't do any harm. It definitely dampens the physiological response, but also had some additional psychological benefits. And it seems to be that the earlier you intervene, the more likely you are to get a longer term resolution of symptoms. So I think that for me would be the key message. I've been doing some studies looking at the time of death, and that's why I presented some of the studies earlier around predictors. And you know, during COVID, relatives haven't been able to be at the bedside when their loved ones are dying. And so we've been doing a lot of work around providing memories for the relatives, you know, taking photographs, doing fingerprints and interventions like that. And we've just finished a study on that to seeing if that will actually decrease the psychological and cardiovascular impact. So the story is not finished. I think one solution is to look at medication for some people, but it's not the solution for everybody. And I'm personally looking at other solutions. Over to you, Dr. Mihailidou. I'll just
you've summarized it beautifully.
Oh, thank you. Yeah, so we have overrun a little bit, but big thanks to Professor Buckley and Dr. Mihailidou. If there's no further question, maybe hand back to Nelly. Thank you, both speakers. Thank you so much.
Yes, thank you, everyone. Thank you, Professor Tom Buckley and Dr. Anastasia Mihailidou for this wonderful presentation. And thank you, Eric, for the moderation. And this is the evaluation time. We love to hear your feedback so that we can make better webinar in the next time. So please leave us your feedback in the evaluation form. And for medical practitioners who are going to claim CME points, please complete the evaluation form so as to secure the points. And because we are holding different kinds of events in the future, you may follow our Facebook page or LinkedIn page and our webpage to stay tuned to our future announcements. Thank you very much. And thank you, Tom. Thank you, Anastasia.
Thank you so much. Have a good day.
Have a good day.
Look forward to seeing you soon. Bye-bye.
Yeah,
bye now.
bye-bye.
Take care.
Thank you.
Bye now.
Thank you. Bye-bye.